Okay, very good. Good evening, everyone. I welcome you, each one of you, to the IAPC webinar on World Patient Safety Day, a dialogue in palliative care patient safety. This webinar is being organized to celebrate today's World Health Organization observance, World Patient Safety Day. While the WHO has chosen the medication safety to be the theme of this year's observance, we at Indian Association of Palliative Care wanted to broaden the canvas and talk about various facets of patient safety which we all need to be mindful of while working in palliative care in addition to medication safety. The Indian palliative care community specifically is growing rapidly, that we can observe and we can feel it. And we therefore felt that it is important for us to focus on ensuring patient safety, irrespective of the stages of our organization's growth or size of the institution we are working in. So wherever you are working, it is important to take care of patient safety on top priority. This webinar will therefore touch upon the various components of palliative care patient safety, right from the biopsychosocial aspect of patient care, with a focus on quality, and also highlight to you the various ways and approach of adopting palliative patient care safety practice in your everyday practice. As we all know, palliative care is now soon emerging to become one of the most important global public health issues, the way we are going, with increased dialogue around quality of care and quality of time. Before we begin, I would like to thank all my dear friends and panelists for accepting our invitation on a very, very important and precious weekend, and for willing to share the rich experience with us through today's webinar. Each one of these panelists will be introduced to you in due course. So before I hand over and introduce our moderator of the panel discussion today, I would like to introduce our keynote speaker, Dr. Atre Gongli. Dr. Atre Gongli, I think many of you must be knowing Dr. Atre, but it is very important that Atre is one of very good friend of ours, or I can say that Atre is a good friend of palliative care community of India. Atre is a public health professional having experience in implementation of various national health programs with formal training in medicine and public health. Dr. Atre has worked as a clinician and public health specialist in different areas of public health. Working in World Health Organization India since 2010, she is presently the focal point of palliative care at WHO India. So whenever there is something we have to communicate to WHO India, it is the only link between us or ministry and WHO is Dr. Atre. Her major achievements include supporting the Ministry of Health and Family Welfare in the strengthening of national program for palliative care, which deals with provision of palliative care at district and sub-district level. She supported the development of guidelines, which has already released technical and operational guidelines for palliative care package for healthcare and wellness centers under Ayushman Bharat initiative. Further, she is also the focal point of health aging and mental health and substance abuse at WHO India, providing technical support to Government of India for strengthening public health system to cater to the growing health needs for mental health, palliative care, and healthy aging. In the past, she had been engaged in many other areas like adolescent care health, National AIDS Control Program, Reproductive and Child Health Care Program, NCDs, etc. Her experience ranges from community to policy level. At personal level, Atre is a very good friend of whole of community of India as well as mine. She is very soft spoken, very polite, and I should say that she is a very intelligent person who can really connect ministry and WHO, palliative care community and WHO. So, Dr. Atre, we are very, very fortunate that you are here with us. Please go ahead and say whatever you wanted to say in your keynote speaker. Everyone is waiting to hear you.
Thank you, ma'am. I'm really honored and flattered the way you have praised me. I really wish I'll be able to. Am I audible?
Yes, you
Yes,
are.
so I really wish I'll be able to keep up to your expectations. Definitely, the role of WHO is to be a link between the ministry and other stakeholders, and I would love to play the part to the best of my ability. So, at the outset, many congratulations to Indian Association of Palliative Care to organize this very important dialogue on on palliative care through the patient safety lens. Yes, it is very important to have to provide services, but at the same time, the quality of services are also very important. Keeping in mind that no errors are there, so that it does not cause harm than good to people. So, as shared by Dr. Bhatnagar, yes, the theme of this year's World Patient Safety Day is medication safety. It has been seen that medication harm accounts for 50% of the um, overall preventable harm in medical care. And I must say that it is our duty to ensure that we are able to provide the much needed care to people, keeping in mind and avoiding the avoidable and preventable errors at our end. So with these words, esteemed panelists and our august audience, I would really call upon to ensure that we all have a role in maintaining the medication safety. And the mantra "no check and ask" is the mantra to ensure that we are able to fulfill our duties. Also, now coming to palliative care, we know that palliative care is a real crucial part of the healthcare being provided, and it is a very integrated approach which is very people centric. And because there is these days there is increase in the non communicable diseases, also diseases like HIV, wherein people are having a longer longevity. Then neurodevelopmental disorders, neurodegenerative disorders, trauma, etc. Palliative care need is growing day by day, not just globally but also in India. And we have to keep pace and provide the much needed support to our patients. Definitely, we know that the need for palliative care is rising, and it has been estimated that 78% of adults who are in need of palliative care are actually living in low and middle income countries like India. So you can well understand that globally, if we consider 5 people, then 4 of them are staying in countries like India, where resources are definitely very limited. And thus, so what is happening is that only 14% of the people who need palliative care are actually receiving it. So when there is a resource constraint, then the quality on many occasions get compromised. But I'm really happy that we have this a pool of dedicated palliative care experts and specialists in our country, who are providing relentlessly the quality care which our people need. So there is a small film from WHO. If Archana can play it, then we can further take on our discussion.
Sure, ma'am.
Miguel is 35. He is an experienced, dedicated professional who loves his job. He swims every morning and likes to read. He also loves spending time with his family and friends. But for a while now, he hasn't been feeling well. He's tired with no drive or energy. At times, he feels short of breath. He has consulted several doctors who have done many tests. This morning, the specialist brings bad news. He has been diagnosed with severe heart failure. There is no possible cure. Miguel's world comes crashing down. The cardiologist is compassionate and caring. She tells Miguel he could benefit from palliative care to alleviate his symptoms and improve his quality of life. Miguel has a lot of questions. Some are very profound. Is it worth living like this when there is no cure? Others are more practical. And what is palliative care? Is it too early to talk about this? The cardiologist reassures him. Don't worry, Miguel, you will not be alone. She explains that palliative care always puts the patient at the centre of care, that the care units are multidisciplinary teams of devoted professionals and volunteers, that they care for patients of any age and any state of the disease, not only right at the end of life, and that alongside his loved ones they will partner with him to ensure the best quality of life. When he meets the team, the nurse explains to Miguel that palliative care can be thought of like building a house.
Everything starts with strong foundations. In our country, we have policies to ensure palliative care is available to all people when and where they need it.
A volunteer from the team also tells Miguel that involving families and communities is crucial. Research then makes up the floor of the house. Palliative care is based on the best scientific evidence and knowledge.
Education and access to medications are the walls of the palliative care house. Your team is well trained and here to manage your pain and symptoms.
The team psychologist explains. When the walls are in place, the roof can be put on. In this case, the roof is when quality palliative care is available and integrated into all levels of the healthcare system. Miguel can see the house being built around him. He now feels much more secure. You can feel at home here, says the cardiologist. Life is worth living every day until the last one. We will be with you.
Okay, thank you so much, Archana, for playing. Why I chose to have this on, because I know you are all from the palliative care fraternity, and maybe it may sound repetitive, but you know there are many things which we in India have in like in terms of policies, in terms of how to reach out to families. Families in India are still having that connect, although the community, although the families are no longer the joint families, many of them have become nuclear, yet the connect is there. There is good research being done, and the members of IAPC are contributing to it. Education is there. The government has brought about many courses in palliative care. MD palliative care is also starting. We also have the medications being provided in so, and also the services, the government is making efforts. So in order to achieve the sustainable development goal 3, we have to take forward the palliative care services in the right earnest, or else we will not be able to reach out to the people, the millions of people who actually need care. Palliative care definitely needs a primary healthcare approach, and much of it is there in our country. Also, if we have to ensure the quality, they have to be assessment tools to see whether the work with the palliative care services that is being provided is as per the protocols and the quality is maintained. And it is a very important aspect of any care, that we cannot do things by ourselves. We have to form a team within the medical fraternity and also outside. We have the even in the IPSC, we have IAPC, you have members who are from academia, government colleges, private colleges, NGOs. So it is very important to get together and go for the ultimate objective of providing quality palliative care to the millions of our countrymen who need it. And WHO has been giving guidance, and we have many of our esteemed speakers today, and Dr. Sushma, who have been a part of many of WHO deliberations. The resolution in 2014, it calls for creation of national policies, and we are really fortunate in India that we have, although we don't have a direct policy, but we have a national program which has been able to reach out to about 500 districts currently. And then many advocates have been advocating for availability of opioids, and the revision of the NDPS Act in 2014 is an outcome of the hard labor of many of you all. Dr. Sushma is one of the leaders of there, and there are many others definitely. Then training, the national program, once it was introduced in 13-14, then we had a committee created, which was a technical group which created the modules, and then the different cadres of healthcare providers under the national program were trained. And very importantly here, I would say that the training here was not only just on the medical aspects, but the psychosocial aspect was also taken care of. And very importantly, in palliative care, we must encourage task shifting, because not everything can be done by the doctors. There have to be, certain things can be done by the nurses, certain things can be done by the community health workers. So definitely, these are positive steps in our country. And finally, the integration of palliative care services into the existing healthcare system, because the national program is not a standalone program, but it is under the umbrella of NHM. So it provides palliative care not only just for the cancer patients, but as earlier palliative care was thought that it would be, primarily for the cancer patients. But now, as I said, the growing number of NCDs, people aging, so it is across all patients who are provided care under the program. Also, the Ayushman Bharat initiative has been really innovative in having the palliative care package in their delivery of services. So it is even more important that we reach out to the community. Very importantly, I would say, apart from the quality, we also need to ensure the home-based palliative care to be extended to all patients, because palliative care, many a times people coming to the hospital, or people being admitted in the hospital, may not be possible, and at home they do not get the right quality of care, because maybe the family members are not trained well, or the consumables and the necessary medications may not be available. So it is always important to ensure the quality, and that can be done through home-based palliative care. Home-based palliative care also has an advantage that it gives the family members reassurance that not everything is over. There is still positivity, and also takes care of caregiver burden, which is also one of the caregiver distress, or give some relief to the caregivers through the psychosocial support which the palliative care team has been providing. So since we are today on the Patient Safety Day, it is very important to understand that it is not just the provision of care, but how the care is being provided, in terms of the delivery of care, in terms of the quality, in terms of the uh, the frequency of visits, or etc., are very important. And therefore, my earnest request to this August gathering, that we all get together to ensure palliative care to the people, not only just quantitatively, but also qualitatively. And I end with the another congratulation to this this gathering, this IAPC, that they have been able to, they have been a support to the government, because many of the members of IAPC had played an active role since the national program has come up, and they have been the trainers and resource persons for various trainings. And it is only through training that quality can be ensured. So thank you once again for giving WHO an opportunity to be a part of this event, and I wish the event the very best so that the objectives of the events can be achieved. Thank you.
Thank you, Dr. Atre. Thank you for giving WHO perspective and representing WHO in our seminar. And I think it was an absolute honor for all of us as a palliative care community. I am really grateful on behalf of all the palliative care physicians of India that you represented today, WHO, and you spared your time and given your valuable comments on this group, to this group. Now, I would like to introduce our moderator. Before introducing our moderator, I want to introduce three more people in this to the group: Archana, Nisha, and Savita. These are the three people, those who are, I think, since last almost 3 months, they are working on this. That this should happen, and this should happen in a grand way. And finally, this is happening today. So I just want to introduce Nisha, our National Information Officer, Archana, our project officer of Indian Association of Palliative Care, and Savita, Secretary of Indian Association of Palliative Care. There are many people, those who are involved, and I think we will definitely introduce them and thank them in the last, but I wanted to introduce you all before, because this is their hard work which has given us this wonderful webinar today. Now I will introduce our moderator, Dr. Joyita. We all know, I think everybody knows Joyita in this country, but still I want to say something about Joyita. Joyita is heading the Department of Palliative Medicine at Tata Memorial Hospital. She is also our Central Council member of Indian Association of Palliative Care and helping IAPC in various ways. Wherever there is a support needed to IAPC, Joyita is always there to help. And that's what she did today for this webinar, that she said, I will moderate. So thank you, Joyita, for accepting our request and considering this is our own program. And Joyita is a very lovely friend of ours and for mine. And one more thing I want to say, that Joyita is an excellent teacher. The more I'm listening to your lectures, I'm becoming a fan of your teaching. Thank you, Joyita. Please go ahead.
Thank you, Dr. Sushma Bhatnagar, ma'am. You always do such a kind introduction, and I never get enough of it, so I will not say no to that. So thank you very much for inviting me to be moderator for this important program. And of course, thanks to all of the IAPC community and the Secretariat who have worked so hard to get this program. So we have this, you heard from Dr. Sushma. Yeah, I'm presuming that you all can hear me because nobody has shown a fit yet. Yeah, okay. So you can all hear me. And we have this, and I think it's a great activity. And thank you, Dr. Atre, to make this perspective so clear from WHO. And we have a friend in you, and it's really very heartening. So let's go on to this panel. And we have this, it's World Patient Safety Day with a focus on medication safety, but we know we are palliative care and hence it is holistic care. So we are going to talk about various aspects and domains, and that is where all our expert panelists are going to be able to help us do this program. So to introduce our panel, we have Dr. Reena George. She is professor and senior palliative care professional in Christian Medical College, Vellore. I'm going to introduce all the panelists one by one so that the last panelist, which is Dr. Shirley, will not feel that we've forgotten her. We haven't. So I'll introduce the panelists one by one. and then of course I'll ask you the questions. Our next panelist is Dr. Shondeep Mukhopadhyay. He is Deputy Director of Indian Council of Medical Research and is in the National Institute of Cholera and Enteric Diseases in Kolkata. We also have Dr. Savita Dormai. She is Community Health Specialist in Kuchi Foundation, Manipur, working in a community setting. Our next panelist is in absentia, but we should mention her, Dr. Gayatri Pallat. He is professor at MNJ Institute of Oncology and Regional Cancer Center. However, she is unwell and hence she is not able to take part in the panel, and we will be addressing her questions to our another panelist. We also have Dr. Ganpati. He is the CEO of JASCAP, which is an NGO or working dedicatedly for information, provision of information and care to cancer patients. And he also is a volunteer counselor in the Department of Palliative Medicine in Tata Memorial Hospital. We next have Dr. Shrikant Atreya, who is the senior consultant and head of the palliative care unit of the Department of Psycho-Oncology and Palliative Care at Tata Medical Center in Kolkata. So Kolkata is winning at this rate because there are two people from there. Our last panelist is Dr. Shirley Salins. She is Associate Professor, Department of Radiotherapy and Oncology in Manipal Comprehensive Cancer Center at Kasturba Medical College in Manipal. So with that, we have all the panelists, unless if I have forgotten anybody. No, I don't think I have. So we are going to cover different aspects of patient safety with a focus on medication safety. So my first question is to Dr. Reena George, ma'am. Dr. Reena, you work in a very high patient volume organization, and ensuring patient safety in high volume settings can be such a challenge in all aspects. So from you, we would like to learn what practical strategies do you have or do you suggest for reducing errors in both diagnosis and management at palliative care clinics in large hospitals?
Thank you, Dr. Joyita, and thank you, IAPC. It is true that, in a large volume hospital, continuity is difficult, time is scarce, but then we also need to remember that many of the patients coming to large volume hospitals have come from hundreds of kilometers for the last word. Can my disease be cured? What medicine should I continue? So a careless diagnosis or a faulty prescription on our part can become the foundation for long-term treatment when they go back home. And that's why, even though we are busy, we have a moral responsibility to minimize these errors. So these are just a few practical strategies which I found helpful. And I thought I'd put it in a mnemonic, please, PLEASE. So let's take these letters one by one. So the first P in please would be a proforma that collects the essential information. We had two versions, a detailed one for those who would follow up long term and a much shorter one for others. But, who will fill the proforma? So that is another P, people. And I learned a lot way back in 1998 from seeing the proforma in Dr. Rajgopal's clinic in Calicut, where a kind volunteer actually filled the pain chart, the family tree, the list of medicines, the symptom checklist, the psychosocial concerns, which sometimes doctors in a medical history may forget. And I really believe that experienced volunteers and nurses can do this very well and also provide continuity to the patient, especially in teaching hospitals where junior medical staff come for brief rotations. So a third P from that, please, is to preview. I think we have to preview the medical information before calling the patient in. If we do that beforehand, not only can we listen more attentively, we are in a better position not to make mistakes in diagnosis and in treatment. And having previewed the information, one practical way is for a volunteer just to arrange the previous records in time sequence with the biopsy report right on top. And then the doctor can make a 2-line summary. I mean, just to take an example, infiltrating duct carcinoma, triple negative, T4N2M1, left breast, with liver secondaries and thoracic spine secondaries, progressed on 3 lines of systemic therapy for palliative care, diabetic on metformin. So this summary tells me that this is clearly a patient with incurable disease, and she's at risk for spinal cord compression. And I have that information in my mind when I call her in. But to take another example, if I say squamous cell carcinoma cervix, stage 2B, post-radiotherapy 2 years ago, with bleeding and severe anemia, but no imaging or recent biopsy. So this could be a recurrence, but it could also be radiation proctitis. So when I call the patient in, I have to clarify the diagnosis so that I do not wrongly label a cancer-free patient as palliative. And then she would die of anemia. So how do I make that distinction? That brings me to the second letter in please, L. Listen without interruption for a few minutes before asking further clarifying questions. I think there is no substitute for listening for a few minutes without interruption and hearing the story, because that tells you, does the history that the patient is giving fit with our working diagnosis and prognosis? Does it explain the symptom, or is there something else? And then also, what does the patient understand? Is their expectation matching the current treatment strategy? If my triple negative CA breast patient is expecting a cure, in my mind, a therapeutic error is not just giving the wrong drug, but also when we give the most expensive, in quotes, right drug for unrealistic expectations in incurable disease and push a family into generations of poverty. So then we need to clarify that and clarify the options. But it's very, very possible that even after we make the right diagnosis and give the right prescription, patients may take medications improperly. So the third letter from please is an E, to educate appropriately. We need again to stratify when time is short. So with intelligent or highly literate patients, the educators can give a handout or a teaching video and check what they have understood and just correct any misconceptions. They don't need to say the whole thing. But we also had a separate category called vulnerable patient education. Here we have to take extra trouble. We used to sometimes use color-coded sketch pens to indicate that the red sketch pen medicine is for emergency for pain, the yellow is for vomiting, the blue is for dyspnea, that sort of thing. The fourth letter is A, amplify capacity. Again, in a large volume hospital, when junior doctors rotate through for a few weeks each, there is potential for error, but we have to remember there is also great potential for amplifying services through education. If you teach this person who comes to you for 2 weeks, over so many years, how many more patients will get pain relief? So when a junior doctor comes to discuss a complicated new case, I would like them to bring the chart with a brief summary of their clinical impression, a separate rough paper with a little bit of their plan of management, and their draft prescription. So then instead of everybody saying everything, I can look at that prescription, correct errors if there are any, affirm good practice, and several times I find that I may need to reassess the patient myself. So again, I think this helps active learning. The PG has to think what they would do, and it also helps them remember when they've got it right or even when they've got it wrong. Now, despite our efforts in the clinic, things can get missed, and that brings us to the fourth letter from please, or the fifth letter, S, So screen and strategize. Once a week in the team meeting, there's an opportunity to quickly sample the charts of some of the new or complex patients, and then one can add an alert that next time they come, do this, change this, or watch for this complication in the weeks to come. The final letter in the acronym is E, errors, to anticipate and analyze errors. So let me give an example of each. Anticipating error. If a morphine midazolam infusion is to be started in a ward that is not familiar with it, we would put an alert on the chart to call the palliative care nurse when the infusion is being started. And she sees how the charge nurse is starting it, corrects any mistakes, and ensures that there are handing over protocols in place when the shifts change. Sometimes unforeseen errors come up, and especially on home visits, we find that. And we need to analyze these errors, not to blame anyone, but to understand why it happened and what we can do to prevent it in future. There's a very nice saying which says, never waste a mistake. I think both in medicine and in life, that's a good thing to remember. So to summarize, I think in a large volume hospital, we have an extra moral responsibility to minimize diagnostic and therapeutic errors. Our acronym PLEASE stands for to preview information using an appropriate proforma, to listen without interruption, to identify errors in diagnosis or gaps in communication, to tailor education to patient needs, to amplify capacity through supervised prescribing, to screen charts for mistakes, and finally, to anticipate and analyze the errors that happen. So that's all I have to say. Thank you.
Thank you very much, Dr. Reena. I think you made the practical aspects very, very clear. And I'm sure everybody has written down the PPP, LEASC, and because I have been jotting down. And I think everything like this will be going on to the OPD sheets or inpatient sheets, and we are going to apply to that. Thank you so much, Reena ma'am. Moving over to Dr. Shondeep. I know that Dr. Reena has addressed a bit about the medication safety, but from your perspective from ICMR and talking about medication safety overall, in different healthcare centers and focusing on palliative care, when we are talking about treatment, what are the means of ensuring that we have safe practices? We
You are muted.
can't hear you.
Oh, am I audible?
Yeah, now we can. Yeah.
Okay. So before I tell anything, I should like to tell that medication error, it is not a thing that that should be addressed only from the hospital level. It may happen even at the home care level. And on the other side, if we consider patient safety, it is not just a medication error. So there are other aspects also. It starts from the point of manufacturing to the supply, to the storage in the hospitals, so at the patient point of care level. So I think I should share a small presentation if you allow me.
We have about 5 minutes, so I mean 7 minutes overall. If you can do that within that, that's absolutely fine. Dr. Archana, please can. Dr. Shondeep is already a co-host, so I think you can share.
So, is it feasible?
Yes, it's coming up. Yeah.
Okay. So we know that these are some basic words related to this medication error. That it is something which is avoidable, and cost associated with medication error is around $42 billion US annually. And in India, we don't have the exact estimate, but in US, the annual emergency visit due to adverse drug event is around 1.3 million, and which leads to around 3.5 lakhs of hospitalization. So errors occur at different stages. So first of all, there may be weak medication system. On the other hand, the human factors. So medication errors, they lead to severe harm, disability, or even death. So what are the human factors? So something like fatigue or a poor environmental condition, staff shortage, this may affect prescribing. At the second point, there may be errors in transcribing and dispensing, and there may be failure in administration part or monitoring practices. So WHO has launched one program like Medication Without Harm in 2017. The aim was to reduce the medication related harm by 50% globally in next 5 years. So multiple interventions to address the frequency and impact of medication errors have already been developed, yet their implementation is varied. So what I have mentioned, that safe medicine is not only the point of care thing, it is starting from the level of manufacturing. If a counterfeit medicine is prepared or if it is supplied, that may put the safety of the patient at a jeopardy. Supply, delivery, storage, poor storage condition, temperature is not maintained. So all these things may lead to problem. But however, these type of things are mostly at the administrative level, either in the government level or at the level of the hospital management. We mostly consider about the patient point of care level. So what can we do for the palliative care scenario? So there may be a level which is point of care level and at the patient level. So Dr. Reena has nicely summarized the thing about the point of care level. Again, at the pharmacy level, check, verify and dispense. At the hospital level, verify, deliver, monitor and report. So this should be at the level of the nurse and the doctor. And educate. So patient and the caregiver must be educated, particularly at the home care setting when the patient is going back to their home and they have to continue some medications. So there is need for some education. So in this part, so patient level, there may be something like a pill card or the futuristic things like the automatic dispensers and digital pharmacies. So this type of things may add up in the level of safety. So don't forget the rights. So when we are dispensing a drug or taking some medication or prescribing something, so right prescription, right drug to the right patient at a right dose, at a right time, in a right route, followed by a right documentation. These are the rights which can reduce medication error and may prevent a lot of deaths. So pill card, I'm just giving you a graphical expression. So pill card is a simple visual way to show all the medicines that a person need to take on a regular basis. So remember, this is for regular basis medicines, not containing the PRN medications. So the pill card, it uses some simple pictures or simple phrases to show each medicine. So like this, the tablets may be shown or the medicines for the diseases, conditions, something like this. So it should not be including the pills, which should be used as needed because patient may confuse. So the complete pill card may look like this. So this is taken from the Agency of Healthcare Research and Quality and available in the CDC site, website. So what you all need, a printer and a computer and somebody who knows to put this small graphics inside a paper. So those who are vulnerable patients, particularly those who are vulnerable, I'm mentioning it because the time is short always and the people are less and the patients are more. So maybe the vulnerable people may be addressed with this pill card system. So this may be simply simplify their medication thing and may add a lot of safety in their life. So old age, comorbidity and multiple medications. These are the vicious cycle from where medication errors may occur and may be fatal, and missing a dose, wrong timing, wrong pill, double dosing, everything may come at the palliative care patients. So digital health solutions are there to help them at their home. So this may be something like mobile app reminders, pharmacy apps, or the pill dispensers with alert system. So this is a simple pill dispenser. So patient reminders, so visual and auditory alerts at the time of taking the medicines. You can see that there are a lot of small compartments. So all these compartments, they contain the medicines. So when there is a time to take the medicine, there will be alert to the patient, visual alert, sound alert, and even if it is fails, then a phone call. If all these things fail, then at the level of caregiver, again a phone call will go, email will go, or text message will go. So this type of things are being prepared, and this may be cost effective also when they are prepared in a large scale. So only one compartment opens, which is designated for that particular day. So this is another system. So reminder system, just to take one pill when the UCAP reminds it. This is a proprietary system. So it warns if you try to take a double dose or take your pill too soon. So this is a pill organizer. Again, it stores the weekly medication in a device and opens as per the need, AM, PM, or morning, afternoon, night, something like that. There are certain online pharmacy apps which puts automatic reminder to take the medication or refill with a prescription. It has ability to track weight, glucose level, etc. It can record the symptoms or calendar to note upcoming medical appointments, etc. So this may be also a great help to the patients who are in home care. Finally, I would say that from the point of view of the government or from Government of India, so I would request everyone to report the adverse events, whatever is happening. So most of the hospitals, medical colleges, they have some adverse drug reaction reporting system in situ. So the doctors, dentists, or nurse or pharmacists, they can report. Even the patient and their relatives can report. So report the adverse events through the pharmacovigilance program of India. So there is a specific form like this, which is put in the right-hand side. So you can access the website of ipc.gov.in, or you may call at this helpline number 1800-180, 30 days, 24 hours. So this is the brief way to remember this phone number. So you can just make a phone call to report some adverse event. So patients may be taught to report their adverse event, or even if there is a suspected drug-drug interaction. So the take-home messages, medication safety, there are multiple stakeholders. Medication errors are avoidable or reducible. Doctors, pharmacists, nurses, they have important role at the point of care level. Patients and caregiver, they need training and education. Digital tools and digital pharmacy apps, they may prevent many adverse events. And don't forget the rights. Remember, if we don't change, we will become extinct. So thank you.
Thank you very, very much, Dr. Sandeep Mukhopadhyay. That was really very concise, and obviously you are, thinking large and something that will help the country at a, widespread level. So from Dr. Reena, please too. Now we have the rights, and it's a good model pill card that we have, and hope we can adjust it and adapt it to our settings. Thank you very much for those practical points, Dr. Sandeep.
Thank you.
We are going to move to the other end of the spectrum now with Dr. Savita. You work in a community setting, Dr. Savita, and we've been talking about patient and hospital, but determining patient safety for our patients, palliative care patients and their families in the community can be even more challenging. So what can you tell us about the importance of having systems in place to address this?
Yes, having systems in place is very important. for patient safety in the community. And I'd like to illustrate this with an example of pain control. Imagine there's an elderly man with advanced lung cancer, and he has severe pain. He's enrolled in the home-based palliative care program, and the doctor prescribes morphine. The home care nurse visits him, gives the morphine at home. His pain is controlled, and he's quite comfortable. And then suddenly one day, he doesn't get morphine anymore. The excruciating pain comes back, and he's severely traumatized and harmed. Where did things go wrong? To analyze this, we need to step back and really understand the chain of events that leads to this man getting the morphine at home. We call this the system of drug supply. It starts with the doctor who sees the patient and prescribes morphine. She gets in touch with the home care coordinator, who then plans the home care visits and assigns a home care staff to this patient. The home care staff then collects the morphine from the base hospital pharmacy where there's a stock. There's someone there who's monitoring the stock. And as the stock of morphine is getting used up, informs the officer in charge. The officer in charge then writes a new order and contacts the authorized dealers to send a fresh consignment of morphine. Now, there can be a problem anywhere in this system. The home care coordinator may not have planned the visits frequently enough. The home care nurse may have got sick and there was no replacement. The person monitoring the stock may have informed too late. The officer in charge may have been too busy and just forgot to write the new order. And the authorized dealers may have had their own problems. Now, having a system in place means that every part of the system, every person who is involved, is doing his or her job in the right manner, at the right time, so that this whole process is moving smoothly. There are no interruptions, and the person is pain-free. Here's another example. One of the most dreaded emergencies in palliative care is the carotid blowout. This can happen with patients who have head and neck cancer. If they have a fungating wound in the neck, as this wound grows, it can erode into the carotid artery and cause massive bleeding and eventually death. This can cause a lot of panic and fear for the patient and for the family members. Now, we can't prevent the bleeding, but we can minimize the panic and the fear if the family members are prepared in advance. And this is possible if we have a good system in place. So what does a system mean here? First of all, we have to be able to identify people who are at risk for bleeding. So we need to have a good training program in place where all the home care staff are trained about these emergencies so that they can pick up those at risk. Then we need to have good communication between the home care nurse and the treating physician about this patient. The treating physician should give very clear instructions and should prescribe anticipatory midazolam. The midazolam should be available in the pharmacy. The next home care visit should be planned on time. The home care nurse should educate the family members about the risk of bleeding, should tell them to be calm, to have dark towels ready, and should also teach them how to give the subcute midazolam. And finally, the family members need to gather the dark towels and keep it ready by the bedside. So all of this needs to be in place. Just having a training program where we train all the home care staff about carotid blowout is not enough. Everything that needs to be in place must be there so that the family is equipped and ready to face this emergency. So this kind of system thinking is very important in palliative care because we work as teams where we depend on each other for patient care. Each of us needs to do our part correctly, but also communicate with the others so that the system works well. It's also important because we're part of a continuity of care. The home care program is not working in isolation. It's in continuity with the hospital, with the community, with the family. And we need to have a system that brings it all together. If we don't have good systems, then there will be many, many errors. And when there are errors, our patients get hurt. And our patients are vulnerable. Many of them are elderly, they're frail, they're diseased, and even at the point of death. So we have to have good systems so that we can protect our vulnerable patients and keep them safe.
Thank you. Thank you, Dr. Savita. You got the whole aspect to the heart of the matter, which is our patient and our caregiver, with two very, very close examples of pain and carotid blowout. So we need to have a chain which is strong. And to make that chain strong, we have to have the system which will involve training, coordination, continuity, and accountability is what I get from, especially when you are working in the community. Thank you so much, Dr. Savita, for that. We are going to shift gears a bit. We have been talking about the physical aspects of safety. It's time to focus on psychological safety, which is equally important. So, Dr. Ganpati, what steps should we be cognizant of whilst emphasizing psychological safety? And I would like you to think about all who are involved in palliative care, the patients, the caregivers, as well as the staff. You are mute. You are mute.
Thank you so much, Dr. Joyita. So since I'm supposed to be covering 3 stakeholders, can I get 2 minutes extra from 7 to 9? 3 minutes.
You can get a minute extra, and we shall not waste time in haggling over more minutes. Okay.
Okay, fine. So as we heard the 3 doctors, the 3 medical professionals before I would take over, we spoke about procedural delays, the system flaws, and the possible errors in the medication, which can be a compromise on patient safety. But all what I understood, the 3 medical professionals essentially focused on the physical aspect of the safety, which of course is very, very important. Unless and until the patient doesn't feel safe, we cannot move ahead. However, the same patient who is a human being experiences suffering, diluting his basic feeling and the basic right of having to feel safe. And that safety is usually compromised because of the experience of suffering. So we are talking about safety that is, that is sought after, safety that is internal, and the safety that is related to one's life that is leading. And therefore, the question is, are the patients safe at hospitals, home sometimes, and in the hospice? The entire trajectory of the patient's travel. Taking a recent example, not very recent, that I had one of these cases where the pediatric just one child who was a case of retinoblastoma. It was palliative, and therefore it was suggested that now the patient need not be be kept in the hospital and can be moved home. So we had the father and the mother pleading to us, telling that This home is very small. We don't have basic facilities. The toilets are not even within the walkable range, and the child is going to feel very difficult to walk. And then he said, most of the time I have to bear the brunt of my husband's frustration. He comes home drunk, and the child has to see all these things. So when we're talking about psychological safety, on one hand, systemically, we want the patient to move to home, because hospital is not the right place, because eventually all interventions are going to be stopped, and therefore the child is to be taken care of, assuming that the home is a safe haven. So from this example, we realize that palliative care patients with very complex needs are increasingly forced to choose, or they're choosing to remain at home for their care. So a home would represent a familiar environment, presence of supportive care, family and friends, potential for normalcy, and a safe haven. But look at this example that I quoted. How different is the scene on the ground? Not much information. Of course, I went through a few studies and I found that not much information is available on care literature where the patient is moved to home and safety is being spoken about. Patient safety has been focused predominantly on an institutional level, but corresponding level of research doesn't exist for safety initiatives where the patients has to be taken care of at home. Extending this knowledge about safety in palliative care, caring at home is important because patients, especially receiving end-of-life care, are particularly vulnerable to the medical errors and safety lapses for a number of reasons. As they have increased exposure to medication, treatments and healthcare system, the patients have more serious effects from errors because they have less reserve to overcome the effects. And lastly, the disease may have caused maybe a cognitive impairment, and these patients are often exposed to pervasive patterns of care that run counter to well substantiated evidence-based practices that is available in the hospital. So we don't know. The question I leave open is, how safe is the patient at home? That's one thing. So now we are going to talk about the most important unit of care which the palliative care system recognizes, that is the family caregivers. So when we talk about family caregivers, they are often ill-prepared for any emergency, and they are perhaps overwhelmed by many demands they face, placing them at a risk for injury and other negative consequences, such as adverse physical, psychological, social, and financial challenges. Coordinated care, optimal medication regimens, advanced care planning, and bereavement care can all make substantial difference in comfort, a rate of exacerbations, and even lifespan. Yet the family caregivers often face a piecemeal array of uncoordinated care elements, making provisions of home caring at home very, very challenging, fraught with risks. So providing palliative care in home requires that home be truly recognized as a distinct place of care and not just an extension of an institution. And therefore, going back to the earlier speakers, training, education, and continuous assessment of the changing health needs and taking care is something that is very, very important. And also, we realize that caregivers often experience sleep deprivation because they provide around-the-clock care, such as administering and managing medications, moving the client, managing medical equipment, providing intimate personal care, such as bathing, toileting, and skin care, etc. This in stark contrast to how the patients are cared for in institutions where there are 2 or 3 shifts of paid professionals prepare and adept at providing these kind of care. So although there is a growing body of research that has begun to highlight the complexity and multidimensionality of caring at home and talking about safety at caring at home, the dearth of understanding of safety issues from the perspectives of caregivers like patients, their caregivers can also be vulnerable due to lack of appropriate skills, poor socioeconomic status, further compounded by their own age-related, fragile health-related issues. And finally, we can't forget people at home, those who are actually being a part of the multidisciplinary team and who are in the part of the hospital who are taking care of these patients. So as we know that optimum care of palliative care patient requires multidisciplinary team, and it is important that each team member is trained to reduce errors in care practices. So periodic assessment and improvements in the coordination of care alongside wider availability of specialist palliative care support may probably reduce the risk. And can increase the prospect of the patients feeling safe. And according to a very systematic review that I read, 67% of staff associated with palliative care delivery wish to have multidisciplinary meetings post-death, and especially in a pediatric case, post-death of a child, they wanted a debriefing to vent out their own, and saving them from a situation of burnout and address the residual feelings of sadness, anger, and anxiety that spilled over in their roles. And finally, there is something called memorable deaths, were often associated with vulnerability that may bring to the surface professional issues of perfection, control, and I'm there, always there. And so long as I'm there, nothing happened to you. The omnipotence that we feel about it, or personal issues like previous losses, personal wounds, and sympathy. So channelizing this vulnerability from being perceived as a sign of weakness to a condition necessary to care for dying is very, very important. It's this vulnerability that gives you the ability to remain open and willing to develop a relationship with the dying and the family. This connection is risky, we know, but can lead to identification with the dying or bereaved person. Many studies have shown that repeated exposure to intense emotions in an unsupported environment may lead to burnout or compassion fatigue. So it's very important that these staff who are part of this palliative care, who are in the toxic environment all the time, are equally taken care of in the form of appropriate break, debriefing post a particular event, or the way that they are given encouraged to follow their own hobbies and talk about self-care measures are very, very important. So that's where I end my talk.
Thank you very much. You did not need that 1 minute extra, but you got all the points through. So you were very good at explaining to us that we are talking about psychological safety. So we are talking about suffering of the patients and the caregivers.
Yeah.
And we may need to ask ourselves, is home a safe environment, not just physically, but as well as psychologically for the patient as well as the caregiver? And and what the other point I get is that we are talking about a vulnerable population, vulnerable for our patients and caregivers, and due to different losses, both patients and caregivers as well as the palliative care professionals are also vulnerable because they are working in this stress-intensive environment. There are good experiences, sometimes there are losses, so we need to take, and you have focused on that psychological safety for all these groups so very well. Thank you very much, Dr. Ganpati.
Thank you so much.
Dr. Shrikant Atreya, you are a public health and palliative care professional. And we know that when we are talking about patient safety, we also need to consider an important aspect like patient preference. So what is the available evidence regarding patient preference, especially in settings like ours in an LMIC? And what are the challenges and facilitators for implementing this in the community?
Thank you, madam. Thank you, Joyita madam, Dr. Sushma madam, and IAPC for inviting me for this very important session. I'm sorry I might be croaking because I have a very bad throat, but I'll still try to convey what I want to convey. So for the first question, ma'am, now it's very important that when we consider patient safety, it's just not about the medication safety, the physical safety, or the psychosocial safety, but also the most important is patient's wishes, the family's wishes, where the patient would like to spend the last days and hours of life. That's very important. Now, as far as literature is concerned, recently we published a narrative review, and there is sparse literature from India per se, but there was an interesting element of literature, I would say, that recently Kulkarni et al. In 2016 published a very important paper on what are the preferences of patients, where would they like to spend the last days of their life. And it was found that 83%, almost 83% of the patients preferred to spend the last days of their life at home. But contrary to this, 67% of the patients actually landed up in the hospital in an end-of-life situation. Now you understand there's a stark difference in what they willed to be and where they willed to be and where they actually landed up, And why this discrepancy? Why the huge difference? Now, I would like to put forth one point is that a lot of our understanding of care is very Western oriented. You know, a lot of our approach is Western oriented. We forget that India is a very different country, has a different culture, and the way we support each other is totally different. Our healthcare structure is totally different. And I would say our healthcare system is absolute chaos. That's an important point here. You know, so what is the reason that 83% patients actually said that they wanted to be cared for at home in the end of life? And what went through? So first thing is, naturally, if I were to ask you this question, so you would also naturally say that, yes, of course, I want to spend the last days at home and die at home with family around. But what contributes to this thought? One is good health. I am always in a good state of health, and a sudden cardiac arrest and I die. That's the best way to die. And that's what all of us perceive and want to be in that state of health. Patients were in good performance status, walking, doing their routine ADLs, and contributing to the family in whichever way they could. They have a good social system, a good social support at home, where families are supporting them in every possible way. And the most important and the salient point that came up in our study was, a good healthcare system, a skeletal system where there was either a GP, a general practitioner in the community known to them who would support them till the end of life, or a good palliative care team or a home-based team who could support them. So these are the very important factors that contributed to for them to be wanting to be at home in the end of life. But what was the contrary, and why was the contrary so? As they reached the end of life, as they reached the other spectra, they became more dependent. They became more bedbound. They became very symptomatic. They had a lot of pain and other symptoms. And they felt that the structure at home was not feasible, was not conducive for care at home, because they had distrust in their own caregivers that they would be able to manage the system at home. Second thing is that also the feeling of burden, the guilt that they were being burdensome on their family members and caregivers was very high towards the end of life, because they had become almost bedbound and very symptomatic, requiring constant care and constant support from the family. And the third, the same point again, was poor healthcare system, fractured healthcare system, where there was not a single general practitioner, poor palliative care support in the community. And as we understand, hospice we talk about, but majority of the hospices, the palliative care communities are focused entirely in the city areas. Rural and urban area, or rural and semi-urban areas don't even have a glimpse of it. So that's the major hurdle where there was a discrepancy in both the groups of patients. They're willing to be at home and actually landed up being in hospital. So this was a reason why, although 83% wanted to be at home, 67, a large chunk of the population actually landed up being cared for in the hospital in end of life. Now, answer to the second question. So almost I've answered the second question and the first question itself. Now, what is that? What are the facilitators and challenges? I'll just club the two and try to get the facilitator out of the challenges also. So basically, what was, as I told you in the beginning, that a fractured healthcare system. Now, in a public health system, we have the rural health system, which is totally different from the urban health system and the semi-urban health system. So patients are lost in the transit. At one point, we have a very brilliant healthcare structure in the rural area with ASHA workers, community health volunteers, going up the ladder to, district hospitals and, primary health centers and all that. But when it comes to urban health system, there's a total different loss, where the patients don't even know who a general practitioner is, what a general practitioner means. They don't even know whom they should approach. That is one thing. Second thing is that, unlike the countries abroad, where we adopt a lot of our principles, we don't have one thing that is a referral pattern or referral system, like what we should ideally think of. We talk a lot of times on referral patterns and referral system. But today, if I were to approach a doctor, I can just go and approach any doctor I feel. There is nothing called as general physician in the community who would kind of be the link point, a point where people are actually being linked to their specialists. That is lacking, which means that the patients fall back on the specialist every time there is a complication or an emergency. Third thing is that, as again, you know, how do we counter this problem? So the most important thing is that having a system in place, which Dr. Savita just spoke about it, having a system in place. And the most important system is empowering the community, one. Second thing is empowering the general practitioners, empowering even the lay workers. Why not even the quacks? In the community, in the rural area, you can't expect an MBBS physician to be sitting and looking after patients. We need to even empower the quacks who can be the point of contact, a pivotal point of contact between the patient and the specialist in the community or higher above. Having a pivotal point of contact matters much. Second thing is an amicable collaboration. What's lacking is an amicable collaboration. So a specialist does not feel that in his presence there is a requirement of a generalist in the community. The specialist feels that everything can be taken care of by us. Don't worry. We have a very good multidisciplinary team. We will ensure that you're being called and you'll be provided. But what happens if the patient is in an emergency at 3 o'clock in the night? The specialist is not going to rush to the patient's house at that time. So the specialist needs to be in touch with the GPs. And second thing is communication. What matters much? I sit at this position here and you are here. That hierarchical approach is what puts off a lot of people. We need to be at a point where we are at par. We need to give them the feel that we are at par and we need to seek each other's help. And you are a very important person in the entire transition for the patient. I am just going to be a support about a layer above it or around it. Second thing is delineation of roles and responsibilities. What's lacking is who is a general palliative care physician? What does a general physician do which a specialist does not do? Or what does a specialist do with a general physician is not already doing? But that clear demarcation has to come from academic centers and higher institutions where there is a clear demarcation of roles and responsibilities of general physicians and specialist cares. Conflict in care. Oh, that's a very important point. And who is the ultimate victim of the conflict? The patients and the caregivers. And what's the conflict about? Oh, the general physician has prescribed you certain medicines which are not even worth the prescription. He has over-medicated you. That kind of brings in a sense of distrust in the general physician, because we need to understand as specialists, we cannot be there all over. We are not omnipresent to be caring for the patients every time. We need to actually empower the general physicians, empower the patients, and educate them that general physicians are an important part of our team. So the conflict has to be reduced between the generalists and specialists, and both ways. So that is important part. And third thing, the family should feel comfortable to fall back on. Whom should they fall back on? They cannot always fall back on specialists, so they need to actually fall back on general physicians. So we need to, as palliative care physicians, it is integral part of our support, our clinical care, that we integrate our care with general physicians, identify general physicians, identify people in the community who can be empowered to provide care for our patients. And that's an important point where patients are at home, be cared for at home, and die at home peacefully. The 83% of the population could be 96% over time. But this is what, as specialists, we need to achieve. We cannot expect that patients will automatically achieve it, or by virtue of them being in the community, they would achieve it automatically. So we need to be sure that we do it for our patients. Thank you. Thank you.
Thank you. Thank you so much, Dr. Shrikant, because you have very nicely interwoven both your specialties, which is public health and palliative care. And you are right, we are different. So we should have, it's different strokes for different folks, and we are the people to think about what works best for us, create this referral system, not to forget the collaborations, and of course, camaraderie. It's not going to say that you do this. It is about let us work together and let me do this for our patients. So thank you, Dr. Shrikant, for that. Coming to Dr. Shirley Salins, you are one of the most important part in all this, because we are talking about patient safety. And after all that we have heard from different panelists, I'm sure you have been thinking widely as to so much to do and what more can I do? And with your interest, with your deep interest in quality assurance and quality control, quality improvement, we would all think that that is very necessary. So what do you suggest about the quality improvement workflow as well as the indicators that we should consider for enhancing safety in palliative care practice?
Thank you, Dr. Joyita. Thank you, Dr. Sushma, for this invite. And I think it's like me putting the pieces of a jigsaw puzzle together. All of you all highlighted important domains or areas wherein a patient safety or quality gets compromised. And if I was looking at it, like when you define quality, there is a mnemonic which is STEEP, and then STEEP stands for safe, timely, efficient, effective, equitable, and patient-centered. And the various domains that the other panelists just brought out kind of just rightly fits into this STEEP, wherein someone spoke on availability of medications in a timely fashion, be it in a home care or in the OPD setting, or safe practice in prescribing of medication. It could be in terms of the right dosing of opioids and the other adjuncts which may be required. It could be efficient use of the drugs, as in you educate patients to use or the pharmacist to prescribe. There was examples of the pill prescriber as well as the other apps, and even patient-centered. So all of these are very important parts of quality. And for quality, it's not a one person or one system which is usually contributory. As a part of a quality improvement or main pillar, there are three main processes. There is the structure or the systems, there is the process, and finally the outcomes. Outcomes are the ones which I just listed, which each one of you brought out as problems today. So the Institute of Medicine or the Institute of Health Improvement brings out one of the main no needless list, in which there should not be any pain or suffering, for which palliative care is very apt. This is one of the group of people looking at mitigating or looking after pain and suffering. So quality improvement is nothing but applying or trying to get that best outcome for the patients through either system or the person changes, through a very systematic methodological workflow or a strategy. So there are different ways that a quality improvement can be brought about. It could be a lean methodology. It could be the IHI itself has its own methodology, or the Stanford Group A3 methodology, which is widely propagated with the EQUIP NCG group in India. So it could be different workflow. Ultimately, what does this workflow do? This workflow is going to link the various problems that you already cited today, as well as a lot of interventions which you already cited today. But when you suggest them as a standalone, saying that this has to happen, does it really happen? It usually doesn't happen, because it is not tailor-made at your particular institute. You need to understand, you may have many headings, or you may say this should or must happen, many guidelines, protocols, SOPs. Many a times they still do not end up happening. This is where I would say that the quality improvement methodology works really well. It is a way wherein you identify your problem. It could be any of the problems which were brought about today, right from prescribing, right from what should be the adverse event monitoring, what could be patient perception. And once you look at that problem, I would say some deep analysis needs to be done in your own center or at different places. I would say multiple places together, bringing about a consensus in the country. So when you do that assessment, so it's like a kind of an audit to get what is your baseline. Everything needs to be linked with data. And when you get the data and you measure it, gives you more meaningful ways as to how the interventions you all suggested, whether they work or not. So the QI methodology, apart from the audit, gives you an understanding what's happening. You look deeper or search deeper to do a root cause analysis to identify what are the various contributory factors why this is happening. It cannot be happening only because of an individual or only because of the system. There may be various reasons. It could be even the workflow in your own department, which you would have never thought would have been the reason for that particular event happening. So that in detailed root cause coupled with what you wish to achieve. So it could be right opioid prescribing. You could have done an audit. You found that the right prescriptions were only in 30%. You wish to improve this to 90%. Keeping that goal in mind from your root cause, when you move on towards interventions, then you tailor make those interventions based on the root cause. Only then those interventions are going to be effective for that particular problem. So it is all the various interventions which all of you all suggested. It could be fitting into different problems, but unless you tailor this to a particular problem and you measure it in a very timely manner and set up systems in place. It could be system of a SOP. It could be system of a methodology of training, education. It could be rightly availability of the drugs. So like somebody mentioned, I think Dr. Reena was talking about that, or Dr. Savita was mentioning that the drug list has to be updated. So right now, one of the palliative care teams in Sri Lanka is looking into this, where they're looking into just prescribing of opioids in an inpatient ward. And they found that the availability of opioids is not there. So what is the system to put in place? You need to devise that system so that, there is a way to keep that while the drugs are depleting, you have a way that the system is set in place, that when it is set, when who's supposed to. So these things are very well be able to implement if you do it in a systematic manner. And that is where quality improvement strategies help in not just implementing, but also measuring your success. Just implementing without knowledge of what's exactly happening is of not very valuable use. So when you implement these strategies and you see that you have achieved your outcomes, it is more satisfactory to see that you've done just by the patient, because ultimately everybody wants that the patient-centered care should be improved. There should not be any harm. And when you adequately measure it, I think that is the right, successful way to achieving that safety for the patient. And that's why the QI methodology would work very well in this setting. Apart from the QI methodology, you rightly asked about what indicators one could look at. Now, various quality indicators have been set up in place. Various bigger institutes, the groups like ASCO have put up for various cancer continuum in terms of treatment. Similarly, for palliative care, there are established quality indicators for performance. So while we look at patient safety today, they could be looking at the right prescribing for opioids. Like I just saw that the CDC has a booklet on safety for prescribing of opioids. So there can be different set of indicators. A simplest one could be what are the drugs prescribed for dyspnea in your setting, or what is the routine consumption of these stronger opioids, or how many patients get more than a particular level of the drug. You set these indicators in your practice, in the sense you'll have to set up in such a way that somebody measures this on a routine basis and you get updates as to what's happening. So these quality indicators are very useful to monitor how you would make these changes and embed them in your system. A lot of people may be doing work which is EMR related or which is an automated process. So you can embed these palliative care indicators into your system so that how many patients actually get pain recorded or various such kind of indicators. And it will then help you keep the safety. Or you can even embed in such a way that when you put a wrong prescription, an electronic prescription, that will not get accepted at all, because that's not okay. It will show you as an error. That is some kind of a modeling that you can put up, or you choose a drug which is not available, it will not show up in this list itself. It avoids the risk of error in terms of patients going to the pharmacy and not getting it or using a wrong prescription. So these kind of system changes you can bring to set up in your practice. So I think quality and safety go hand in hand together. And while we think about doing this, a systematic approach to doing it will help us achieve the right success. Thank you.
Thank you. Thank you very much, Dr. Shirley. You rightly said that all that we've discussed, we have to put it in the perspective of quality. So just speculating what we have is right or wrong, or we are doing right, it's not right. It's we have to get onto on-ground reality, see what we are doing, make the change if a change is required, and then measure the change and how it has changed practice. So thank you very much for giving us those tips and sort of thinking through and working on this even more in all our respective settings wherever we work. Thank you, Dr. Shirley. Dr. Gayatri is not here today, so I was going to ask a question of Dr. Shrikant. But before that, I would just like to inform everyone that we had said that we'll be ending at 6:30, but I think everybody will agree that we are having a very important discussion and we are learning so much from all our expert panelists. So I'm sure we wouldn't mind if we go a little bit over time, about 10 or 15 minutes more, so that we can have an even more comprehensive discussion, if you don't mind. If we can go forward, Dr. Shrikant, thank you for stepping in for Dr. Gayatri today. That is very kind of you. I just wanted, because we've already talked a lot about medication safety, both from different speakers, from different panelists already, from Dr. Reena, Dr. Shondeep, Dr. Savita also said about that. But just a few more pointers when we are talking about medication safety in terms of prescribing controlled medications like opioids. What would be the absolutely essential safe practices that we should follow?
Thank you once again, madam. So the point here is that we start off with very important point is that before we prescribe any medication like morphine or benzodiazepines to patient, first thing comes assessment. And we need to assess our patients to understand really if the patient needs opioids, if the patients need benzodiazepines. Second thing is that an impeccable assessment will definitely lead to the second level is what other drugs can be added on to the opioid prescription. So if we can reduce the dose of the opioids and maybe give other medications concomitantly like NSAIDs or paracetamol or any other adjuvants that can be added, it may reduce the dose requirements for opioid. Third thing is that educating the patient. That's very important, because just prescribing and leaving it at that may not be very helpful, because we would need to educate the patient of how to administer, how to administer the drug, what we need to be watchful of, especially if you're giving opioids such as morphine. When you how many times in a day can you give, how often to give, what are the breakthrough doses required, and also to explain and educate the family and the patient that what are the adverse effects that you would be encountering if at all you have these drugs, and what are the medications that can be given to prevent these side effects. So these need to be kept in place. Second thing is that ensure, most importantly, we talk about opioids, we talk about so many important drugs like benzodiazepines. Ensure that the pharmacy has it. Like just Dr. Savita just put forth. Now, patient needed morphine and morphine was not available. The pharmacy ran out of it. And often it's a problem. Often we face in many centers where we ran out of morphine or fentanyl and the patient is still struggling with pain. So ensure that in addition to being a clinician, you're also, taking up the administrative role and ensuring that drugs are in place for your patients. Second thing is that you ensure that your patients are following up on you. Ensure that when your patients are following up, give them a date when they should follow up. It could be a telephonic, it could be a video consultation, it could be a physical consultation, but ensure that when the patients come back to you, one, come back with a prescription, what was mentioned. I mean, many of us have EMR, HMS, so we can procure our prescriptions and ensure that these medicines are there. But also ensure that when the patients come back, they bring back the number of strips, because we want to be sure that the patients are having the medications on time, because there is a misconception about opioids and benzodiazepines, that opioids are given only in end of life situation, and opioids are being given to expedite the dying process. So this can many times, maybe your patient, your caregivers were quite compliant to your prescription, but there was a distant relative who just came up with a new idea that, oh, ये doctor तो opioid दिया है, so possibly आप last stage में है, तो अंतिम समय बढ़ाने के लिए, कम करने के लिए, sorry, the doctor has given you this prescription. So sometimes this goes in the transits, and when the patients come back to you the next time, you are like, the patient is not having a good pain control, and you keep stepping up the opioid doses and realize that every time the patient comes back with the same prescription. So ensure that the patients come back with strips, empty and strips, both the strips to you, so that you can actually count the number of pills the patient has had. Second thing is, at the pharmacy level, ensure that the pharmacists are educated how to prescribe, how to dispense opioids, how to destroy opioids, how to ensure that sometimes there are triplicate prescriptions, sometimes there are duplicate prescriptions. All these things create a lot of chaos. Ensure that you give a prescription to the patient, and also ensure that when you give a prescription to the patient, you explain to the patient that these are the number of prescriptions that are being provided to you. Ensure that this is given as is to your pharmacy, and the pharmacy is then doing the work of documentation, and ensure that you review the documents on a regular basis, because sometimes we run out of opioids, patients have to go out and take the prescription, and that creates a lot of chaos and a lot of apprehensions in the minds of the patients and family that opioids are not available, how the patient be comfortable. So this is what I feel. If Sushma madam wants to add anything, because madam has been has made the rules for opioids and also has prepared guidelines for opioid dispensation and procurement. So madam, if you could add some points on this, please. I guess you're muted.
I think, Srikanth, you have covered everything. I just want to say one thing, that keeping uninterrupted supply and keeping your patient pain-free is your responsibility. But simultaneously, it is our responsibility that it should not be misused and it should not be overused by our patient. So by giving good education and explaining and keeping a good record, documenting, writing on the prescription, I think all these points are very, very important. And NDPS Act 2014 clearly says that not a single patient should remain deprived of pain management, but simultaneously it is responsibility of a medical fraternity to that it should not be misused, overused, or diverted, or there should not be anything like nobody should, those who don't need medication should not be used these medications. So it is very, very important. Thank you, Srikanth.
Thank you, madam. Thank you.
Thank you very much, Dr. Srikanth and Dr. Sushma ma'am, for focusing on what we should do for safe opioid prescription practices. And you can see that it is not some fancy high-tech things that we need to do. We need to do something very basic steps in order to bring this into practice, in our daily practice. So we are thinking about what other questions, 2 to 3 questions that the audience might have. Some of you have already written beforehand, and Dr. Sushma ma'am has brilliantly put it all, the gist of all the panelists that who have spoken. Thank you, ma'am, for doing that. That's very, very considerate and thoughtful of you. And there were some questions which were being asked, but they have been answered in that. We have one question from Dr. Meenakshi. how do we fix the problem of families throwing away morphine when patient dies? Dr. Shrikant, would you like to answer that? You are mute. How do we fix the problem of families throwing away morphine when patient dies?
So it's again comes back to education and and a good follow-up. As a physician, it's important that we follow up on our patients. It need not necessarily be a physical follow-up. Ensure that we have a telephonic or a video consultation follow-up with the patient. Why that is important is every time you review the drug chart, every time you review the prescription and the medications we provided to the patient, you're actually finding out that these are the number of strips which the patient has not used. So we know that, with some degree of conviction, we know that this patient might survive for so long. Start educating the patient that the availability of the drug is minimal, it's scarce, so they need to come and return it to us so that this can be used for patients who are in need of it, and do not, indiscriminately discard the drug, because this is the need of the hour. And you might have also experienced that to procure this drug, to come to the hospital was such a hassle. So this is something which we need to empower our families, our patients, to make them understand that this drug is very important. And when you discard it, ensure that you don't discard it, to come and return the medication. So many of our patients come back and return fentanyl, morphine, which were not used by the patient. And we use it for our really poor patients who can be helped.
I think, Joyita, beside this, teaching family members that by throwing these medication, it can be so harmful for the society if it can be used, it will be misused by anybody else. So explaining them this is very, very important, that it can be misused by anybody else who will pick up this medication. So this is again the education. I think the very nice section. Everybody has given importance of education at every level, including the family members.
Thank you, Dr. Shrikant. Thank you, Dr. Sushma. We'll take this last point. Dr. Macadon sir has a comment. So please, Dr. Macadon, please, Dr. Stanley Macadon. Arjuna, could you unmute him, please?
Stanley sir, you can unmute.
I can't see myself anyway. That's not important. Thank you.
We can see you, sir.
Okay, that's fine. Thank you, Joyita, for giving me this opportunity. One common thread which has come through all the speakers is our fractured health system. And everyone has given excellent ideas, how to fix it. And I just like to add a little bit to that. And also, we need to follow the so-called WHO World Health Assembly Resolution 2014 of integrating palliative care into all healthcare. And Dr. Sushma is doing such a wonderful job of that, and we need to continue doing that, because we need to make it a political thing and make it a political will. The government has to do it, kind of thing. So a few things that I would like to mention are, any hospital or nursing home which has an ICU must mandatorily have a palliative care department. And that department will take care of the people who are transferred from the ICU and things like that. Otherwise, in the ward, people don't know what to do. And the same small department can also take care of 5 kilometers around that hospital for home care. Otherwise, there's no home care, So if we do that, the city is covered. Most streets have a nursing home or a hospital somewhere. So that's one point. The second is, while we have a department like that, then to integrate, you must have combined clinics. It can be done in a half a day slot for every half an hour slot for every department, and they bring 1 or 2 patients that they feel could be transferred to them. And it's so nice for the family also to see that we are all working together. It's very satisfying. The third thing I want to just stress is what already been said is empowering the family. Now, for empowering the family, I think where everybody has problem is there legal support? we must do what is right. Health law will catch up, but we must do what is right. And what is right can be done by us as a body, when we support and encourage each other. So there must be the end of life care bill is presented to the parliament. It needs to be acted upon, and I'm sure that will give a lot of support for home care. And the fourth thing is what Dr. Atre also mentioned, the source of GPs, we are not using them, that can be used for home care as well. And finally, there are many people, not many, at least we can say a few, who are very poor, especially in the rural areas, or maybe in the city, but there's nobody there to take care of it. So if there's no home, no caregiver, you cannot have home care. So I'm going by the CSI hospital in Bangalore model of, they have 20 beds for geriatric patients for long stay facility in a acute care hospital. That is, so what I'm suggesting is 1 to 2% of your beds, maybe 2 beds, maybe 3 beds for people who cannot have home care, cannot have. So to make their end a dignified end, I think we can provide them good care in the hospital. And finally, the fifth thing that I would like to say is about training. We all have the BLS and ALS training, advanced life support. But when that is for resuscitation, but when that is not possible, the other side of the coin is end of life care. So why not have a combined, training and certification, so then every person who is involved in healthcare, especially specialist healthcare and the trainees will have an idea. Whoever is working in the hospital, the junior most person will know what ALS, because that certification is necessary, especially abroad. Without that, you cannot get a job. So in the same way, ALS and end-of-life care support care could be combined, and this joint certification could be given. Thank you. Thank you for your time. Thank you very much.
Thank you, Dr. Stanley. Always you are very, very practical and give us the step points that we really need to stress on. Thank you so much. And I think when we are discussing World Patient Safety Day on palliative care, then we obviously have to take all those things that you say into consideration and do our bit. So I'm just going to, before I thank my panelists, I'm going to say something which covers what we learned from all the panelists today. And that is, and each word is important and you will realize why. So please do the right practices with good systems, taking patient preference, being psychologically safe, and bring in quality. So I hope I have done justice to all the panelists who have done these specific points. So thank you very much, Dr. Reena George, Dr. Shondeep Mukhopadhyay, Dr. Savita Domai, Dr. Gayatri Pallat, who couldn't come today, but still, Dr. Ganpati, Dr. Shrikant Atreya twice, and Dr. Shirley Salins. Thank you very much. And of course, thank you to Dr. Savita Butola, who has done so much of work for this particular webinar, as Madam said in the beginning, with Archana and Nisha. So Savita would like to say a few words, and of course, Dr. Sushma Madam will be there at the end. So thank you very much for having me as a moderator. I loved being here and I learned so much from you. Thank you so much.
We can't hear her, no? We cannot hear her.
Can't hear you, Savita.
I think she's having microphone issues. Yeah, she says her mic is not working.
So she's writing. I think now we have already.
Savita ma'am, can you put it on the chat, on the group chat?
Yes. So I think we are already, we have overshooted time, but it was so important and it was such an excellent session, Joyita. Thank you, everyone. We have already I have thanked everyone and I have summarized everything. Please go through the summary. And thank you, Joyita. And I would like to thank Archana and Nisha. So beautifully they have kept this session. And obviously Savita. They were after, means like whenever I used to go anywhere, I used to get some message regarding this program, that how to do this. And Archana was, means like picking up everybody, talking to everyone, coordinating everything. And I think such a wonderful staff, and we are so proud of this IAPC secretariat. And IAPC is going, we can see the growth of IAPC. Huh? So, and it's such a wonderful program. So Savita, thank you very much. We can't hear you, but thanks a lot. Thank you, Nisha. Thank you, Archana. And thank you, Joyita. And obviously, Dr. Atre Gongli. So good to see. And जहाँ भी WHO आ जाता है तो एकदम से प्रोग्राम का स्टैंडर्ड बढ़ जाता है. So you are so for improving and really it's like our program's standard, Dr. Atre, and obviously Shrikant, Dr. Ganapati, Sandeep, Dr. Reena, Savita. First time I was hearing you, but you were so good with 2 examples. I think it was such a phenomenal examples. And Dr. Shirley, I think giving a lot of importance on quality always in every platform. So I think it is important, and thank you very much. And hearing Dr. Reena always is so beautiful, and she has given such a beautiful example of taking care of these. Thank you. Thank you very much. Have a nice weekend. And sorry for taking too much of time, but it was important, and we have taken 20 minutes extra. Thank you.